persons, and good morning. Good morning, everybody. So it was a nice feeling coming here at Jodhpur. I'm really thankful to Dr. Pratibha and her team for getting this opportunity to share my experience with you all. I've been looking after this IRIS elimination clinic for about almost 10-15 years. We have got, I think, quite a lot of experience, and definitely we have been enriched by the experiences of the people from All India Institute. So here is a little bit of summary, how do you manage and what is our result. Now, IRIS elimination is an important thing. Now, it marks the beginning of many of our progresses, what you see in obstetric medicine. We can say it is the beginning of fetal medicine because it was started by Liley, who diagnosed one fetal condition by doing amniocentesis and started first successful fetal therapy by doing intraperitoneal fetal transfusion. Later on, related to this, intravascular transfusion also started by Rodek, and then Bang J. Mariji was involved with the diagnosis of fetal anemia by MCA PhD, and Lowe et al. Diagnosed NIPD, non-invasive prenatal diagnosis of D. So these are all landmarks in the progress of fetal medicine. This is also a condition where immunoprophylaxis is available, and this was started right back in 1963, and which has eliminated this elimination because of this RHD in developed countries almost to a negligible proportion. Then why we are talking about? Is it still relevant? What is the pathophysiology? Is it a problem in India, and how do you manage? The management basically depends on four major parts. One, we identify the fetus as risk of severe anemia. That is the main pathophysiology of RHD elimination. We monitor for anemia, and whenever we think that fetus is at risk of having severe anemia, give intrauterine blood transfusion 2 at a time when you think the baby can survive ex vitro. Neonatal management is an important part of its management, but I'll not talk about it. That's a part of the neonatal disease. What it does, it basically causes hemolytic disease of fetus as well as newborn. In fetuses, it presents with anemia, which may vary from mild to severe, and in newborn, it presents with jaundice as well as anemia. Effects will be, it can vary from eye drops, it can cause stillbirth, it can cause neonatal death. There may be requirement for exchange transfusion, and if not treated properly, the baby may live with the problems of connectivity. Blood transfusion reactions also is an important problem. Atypical antibodies are present in the mother's blood. Now, this is not surprising. Each RBC is a packet of antigens, and there are 30 different blood group systems, and out of that, there are 329 different RBC antigens. A mother and fetus, there may be mismatch in any of them. But even then, there are only 50 different RBC antigens which has been found to cause serious hemolytic disease of fetus and newborn. But most of these is because of RHD antigen. Other antigens of the same blood group system which are important in the are the C, and other E. Apart from the RH system, KL, Duffy, and MNS system also is important. So it is not altogether going to get completely eliminated on this problem of RBC elimination, though it can reduce the elimination because of this RHD itself. RH system is very polymorphic, and there are 40 independent antigens. It is not that just 5 antigens, but that is what you know of, and for matter of clinical importance, these are most important. Globally, the prenatal deaths have come down from 46 to 1.6 per 100,000 births related to this RHD elimination because of this immunoprophylaxis. But India, well, it is difficult to get the data. There has been one estimate by Alvin G. Proxy, and what he has done, he has taken it that, okay, the average prevalence of RH negativity all over India is around 5%. And so by that, there will be 13 lakh, almost 13 to 14 lakh of RH negative women. Now, out of this, the women at risk that is the father or the husband, is Rh positive, will be around say, 10 to 11 lakhs. Now from that, they have calculated that how much of this RHD, anti-D were used. And from that, they calculated that almost 8 lakhs were not treated. So from, say, I would say 70% that maybe have antibodies, around 1.3, 1 lakhs found to have antibodies, and around 56,000, 56 or 57,000 annually are likely to have serious problem because of this RHD elimination. Hospital-based studies, one from South India and one from Delhi, have shown that 9.3 to 10% of women, Paras women, do have antibodies to RHD in the circulation. In India's, in our center, the Rh negative, this in pregnant women is around 5.9%, but alloimmunized out of them will be 15%. And 44% of them had received intrauterine transfusion. All of them, except one, had anti-M, the rest of them had anti-D as a cause of HDFN. Why it occurs? Because the RBCs with the positive cells come into the metal circulation through the placental barrier, which is not impervious to these RBCs altogether, and produce the immune response. Initially, it is IgM, which does not cross the placenta, does not cause any damage. But with the next challenge, there will be production of IgG, which can cross the placenta and covers these fetal RBCs, which are positive for RHD, and they are destroyed in the reticular endothelial system, causing anemia. It can occur silently, without any problem, and that varies from first trimester to third trimester. As the gestation increases, the risk also increases. As little as 0.1 ml of fetal blood can cause alloimmunization. Apart from that, mismatched blood transfusion in another cause, but most of the time is anti-small c is involved in such cases. Antenatal events, all you know that abortion, amniocentesis, CVS, and antepartum hemorrhage, these are all causes of the excess fetal maternal hemorrhage. There is also a theory that maternal fetal hemorrhage, then whether the patient was in utero, the probably has received Rh positive blood cells from her mother and had got immunized. But there are many factors, because not everybody will be immunized, even if they do not require anti-D. Only 70% do get immunized. Avian incompatibility to some extent is protective, and there may be non-responder in 25 to 30%. So what immunoprophylaxis is done, it has reduced the risks from 70% to 3.3% when you use both postpartum as well as antepartum prophylaxis. The usual response, initially the mild anemia is well tolerated by the fetus, but as the hemoglobin deficit increases, the erythroblasts appear in the circulation, the fetal COT increases, tissue hypoxia ensues. With severe anemia, there may be hydrops, but in earlier pregnancy, there may not be hydrops, while the baby dies of severe anemia and intrauterine fetal death occurs. The fetus, obviously, who are Rh positive, will be the fetuses will be affected. How much affection will be there, it depends on antibody level to some extent, the placental transport of the antibody, and the fetal response to it. The previous history of affected fetus or neonate is very important part, because if there is history of previous stillbirth or previously affected pregnancy, that increases the chance of affection in the present pregnancy. If the previous fetus is mildly affected, then it is likely that, okay, it may not be that severe. Now, there is a concept of critical antibody titer. It varies from laboratory to laboratory, but in our center it is 1 in 16. That is, semi-quantitative test. We see how much antibody or anti-D is there in the body, and if it is more than or equal to 1 in 16, then there is a chance the baby or fetus might be affected severely in utero, and there can be hemolytic disease of fetus and newborn. Now, this thing is good, particularly for the first affected pregnancy. But if the patient had history of RHD-related losses in the past, then we do not depend on this critical titer that much, because anytime it can go very high, even if at the beginning it was low. So that's why first history of hydrops, intrauterine fetal death, extended transfusion, these are very important in its evaluation. What I do in the first visit, the AVA blood group and the first blood group is very important. And if the father is found to be RHD positive, then indirect Coombs test is done. This is to see basically that whether atypical antibody is there in the mother or not, and then I type what sort of antibodies are present. And then semi-quantify with indirect Coombs test. Now, dating is very important in the management of the RHD in any pregnant women, but more so in case of RHD anomalized women. Other routine antenatal tests will be done as per routine. Then, as I said, if it is 1 in 16 or less than that, then we do it every 2 weeks in the first affected pregnancy. And if it does not go more than that, we may not do the screening test for fetal anemia, and we can deliver safely at term around 38 weeks. But if there is history of affected pregnancy or the IC titer anytime is more than 1 in 16 or equal to 1 in 16, then we need to monitor for screen for fetal anemia, and these days it is universally by middle cerebral artery peak cystic velocity. So depending upon that, if you find that okay, it's likely to be severe anemia, then you go for chorosynthesis and fetal blood transfusion. And if you think that okay, everything is okay, there is no increase, then we can deliver at around 36 or 37 weeks. Now this is important. Non-invasive prenatal RHD genetic diagnosis from cell-free fetal DNA. It has become possible these days. Now, you can diagnose whether the fetus is Rh positive or negative with almost 99% of sensitivity and accuracy of 96.5%. This is feasible provided you are certain about the reliability of the laboratory. In such cases, you can determine the paternal zygosity because it's homozygous. There's no point. All babies will be Rh positive. If it is heterozygous, then only there is a point. If you don't have that facility, then you can directly go with NIPT. Now, we have got experience from a small study, and we found that overall sensitivity was at 98.5%, specificity was 75%. But there were 2 false negative tests, and that is worrying. We are not routinely doing this. At present, we are depending on the MCPSV. So, middle cerebral artery peak systolic velocity is important, and that should be the technique of choice to detect the suspect fetal anemia. Anytime if the MCPSV is more than 1.5 mm for that particular gestation, one should suspect either moderate or severe fetal anemia is there, but it should be done correctly. The false positivity in the first test, the first bigger thing was published by Mariji. It was found to be 12% false positivity. But if you do it repeatedly, then the false positivity can come down. So don't depend on one value. You can repeat it again, maybe after 1 or 2 days, at fetal rest, and then the positivity or the false positivity comes down. Again, determination of gestation age is very, very important. Now, why it is important is middle cerebral artery peak systolic velocity. Anemia causes hyperviscosity as well as increased cardiac output. Hypoxia causes a cerebral vasodilation, and that increases the middle cerebral artery peak systolic velocity. What is the optimal technique? As you do in case of BPD measurements, just go below that, take an axial section of fetal head at the level of sphenoid, image the cycle of Willis. I'll show you the video of that to some extent. It should be zoomed. MCPSV should be sampled near its origin from the inferior carotid blood. The direction of the ultrasound beam and the middle cerebral artery should fall on each other so that it becomes as close to 0 as possible. If this angle more than 15 degrees, then the fallacy should be higher. Excessive pressure should be avoided. It should be done during the fetal rest. There should not be fetal breathing. If there is fetal breathing, it can be spuriously high. Now this is what it should look like. Okay, this is a middle cerebral artery. It has been started starting from this lower down. This is the cycle of Willis. This origin, as near its origin, is being sampled. Now, if you take repeated measurements, and if you do it, draw the scalp, then if it is very steep, as you see here, it will be suggestive of severe anemia. Whereas if it is below that 1.5 mm all throughout, it is mild or may not be effective. It is reliable from 15 to 35 weeks. So we start around, say, depending upon previous history, we can start at 15 or maybe at around 18 weeks. After 35 weeks, the false positivity increases. But in such cases, what you do, we see the previous values and how it is behaving, and then we decide whether you can wait or continue pregnancy or not. What is the degree of anemia which will require transfusion? What do you mean by this severe degree of anemia? We take, at least it has been found, taken by other authors also, that PCV, irrespective of gestation, is less than 30. Okay, that should signify the moderate or severe anemia. Others have taken hemoglobin deficit, which is more than 4 gram per DL or 4 SD below the gestation. Now, this is a summary. So, basically, we do husband's blood group, mother's blood group, do ICT, and then ICT titer, see the previous history, start doing MCBSV. And whenever it is more than 1.5 MOM and gestation is less than 35 weeks, we do the fetal blood sampling and intrauterine transfusions. More than 35 weeks, well, if it is, then one can think of giving steroid and deliver. Site of transfusion, intravascular transfusion is preferred, and it is in the umbilical vein near its cord insertion or intrahepatic portion of the umbilical vein or intercardiac even in very early pregnancy. We don't have that experience, but do have experience with the intraperitoneal, which we had to do in about 16 or 17 weeks gestations. Combined, it has been found to be helpful in certain by authors. We haven't found to be helpful and don't use it in practice. Right. Umbilical vein is good, but it is easy, but provided the placenta is anterior, but there is a problem of cord artery puncture and it might be difficult in very early pregnancy. Free loop cord easily is avoided, but in difficult situations, certain situations, you may have to do it. Intrahepatic portion, that is, we prefer, particularly when there is early pregnancy and when the placenta is posterior. There is lesser chance of fetal bradycardia, but fetal bradycardia even then can occur. And again, if there is any bleeding from the puncture site, it remains in the interperitoneal cavity and that's absorbed in the circulation. That's one advantage of it. Combined, it may reduce the number of transfusions, well, but the recent studies suggest it does not.
Last 2 minutes.
Okay, ma'am. Okay, sir. So, in high drops, it is useless. This organization is important. We need a team, and then you need some instruments. This needle what we use, 20 to 22 gauge, along with this becronium, which is used for fetal paralysis. So we do it routinely. The blood should be O negative with a PCA of 70 to 80%. Amount of blood to be transfused, we use this formula, the estimated fetal weight into 0.02, that will increase by 10%. Target is about 45 to 50%. In case of high drops, we go slowly. The first transfusion go up to 25 to 30%, and next go up to 40, 45%. The technique, take informed consent, this is important. Check donor blood status, check equipments, MCFSB again, choose a site, and then prepare the metal abdomen, NTG patches we do use routinely. Fetal paralysis, particularly if you are going into the intrahepatic portion, it is intramuscularly. If you go into the cord, then also use, but it is intravenously. First sample must go for ABO, blood group, hemoglobin, bilirubin, and DCT, and then you give the transfusion. Now, this thing is not working. I'll see a few videos if it is there. That's the middle cerebral artery peak systolic velocity, which is being taken. This is where we have planned that we will go into the cord. So, under direct ultrasound guidance, we go into that cord insertion. So what we are doing is we are just checking where the artery is and we are trying to avoid it and directly going into the vein. So from placenta directly into the vein, so whenever you take it out, there will be less chance of bleeding anywhere. So that's why a little bit cautious when we enter in it. Now this is what you do if we have to give intra hepatic vein. We go into the muscle, paralyze the fetus, and then we go into the intrahepatic portion. This is a thing which shows that how we go. This is the intrahepatic portion of umbilical vein. We guide without sound into the vein. So, right, so that's the needle has come, we check it, and then we give the transfusions. Subsequent transfusions, usually in case of high drops after 24 to 48 hours, and when of the PCB is less than 30%, we go by the calculation 1% drop per day. We also go by the MCPSV. MCPSV up to second transfusion is quite helpful. Even then, after also, it is helpful. So we do depend on MCPSV in almost in all cases. Complications, transient fetal is quite common. Hematoma formations, intrauterine infections, intrauterine fetal death, and requirement for emergency C-section. Total complication rate is around 3.5%. Prostate-related loss is 1.6%. There may be maternal complications, which is quite important, particularly formation of additional antibodies and multiple. This is very important. In our experience, well, in absence of intrauterine high drops, the results are around 59 to 60%, and in presence of no high drops, intrauterine transfusion 90% salvage, which is more or less equivalent to others. The experience is quite rewarding. Though it is not a simple treatment, requires skill, but rewarding experience. Thank you very much.